All right. Welcome everyone to our first webinar of our three-part series on extreme heat and child health, hosted by UNICEF, the Children's Environmental Health Collaborative, and the Global Heat Health Information Network. We planned on hosting this series during the peak summer period here in the Northern Hemisphere because the work we'll be presenting will feel that much more tangible and relevant now as we're all kind of struggling through the heat together. We will be joined by these following presenters during this 90-minute session. And we hope that you'll stay for the entire thing because we'll have some Q&As in between, and also at the end for the panelists for an opportunity for them to answer your audience questions. And we'll have polls in between as well to get your thoughts. All the questions for today can be asked in the Q&A function, and we promise that that's what we'll be using to lead the Q&A session at the end. Before we jump into it, we do have a quick warm-up poll for you guys on how we're cooling down. So I'm going to launch the first one here. So take a moment. We'd love to hear from you on what your favorite thing to eat or drink is to stay cool in the summertime or when there's heat waves. If you don't have a summer, maybe when it's extremely hot outside. All right, great. We have 11 answers. Was good. 18 answers. I suspect a lot of people might also say water, but I'm hoping to also be inspired. Okay. Great. A lot of you have responded to this question, so I'm going to end the poll and we're going to share the results. And what do the results say? Lynn, do you see the results?
Yes, are you able to share, or do you need me to share the results?
It's saying it is being shared. Could you share?
So we have 22 responses. Water was the most popular. We also have ice cream, gelato, watermelon, which was what I put down myself personally, sushi. I love the suggestion. Iced tea, fruit, coffee, and freezies. I'm not sure what freezies are though.
I think
Maybe
those
that's
are
like a smoothie.
popsicles. Maybe,
Okay.
yeah, maybe like shaved ice, if I remember correctly. I'm curious what our panelists also put down. Mrs. Kathleen, what do you do to cool down in the summer?
Here, people like go to the rivers in addition to maybe drinking, something fruity made from fruits like a smoothie. But yeah, going to the river, going to the beach to stay cool and at the same time to stay hydrated.
Excellent. Thank you. Okay, so we have one more poll to kind of figure out what people around the world are doing. Or no, actually. So let's stop sharing that one. And then close that. And then one more poll back is, do you know? Ooh, okay. Yes, do you know? So this is testing whether we can recognize symptoms and signs of heat stress, or sorry, heat stroke, when we come across someone experiencing it. So I'm very curious what people think are the common symptoms of heat stroke. And then we'll have Dr. Caleb Dresser come in and tell us what the latest research is showing. Okay, I see. A lot of people seem to know the most common symptoms, which is excellent. This is great. Excellent. Okay, we have about 50% of the audience responding to this poll. So you know what? I think we're going to call in Dr. Caleb Dresser to come in and tell us what's correct, what's incorrect, and what is actually misinformation.
Hi there. My name is Caleb Dresser. I'm an emergency physician based in Boston. So heat stroke is really diagnosed through two things: high core body temperature or hyperthermia, combined with altered mental status or some neurological change indicating that the brain has overheated and is not working properly. So the first answer and the last answer here are clearly symptoms or signs of heat stroke. These are the things we would want people to take away and be ready to recognize and ready to intervene on in a patient or a coworker or a family member that is exposed to high temperatures. Excessive sweating is really interesting. This is in the teaching as classically being more about heat exhaustion. People are going to tend to be really sweaty with heat exhaustion, which is a step on the road to heat stroke. What gets a little complicated is if you're working with athletes or people doing really heavy outdoor labor who develop exertional heat stroke, they can actually be sweaty when they develop heat stroke. So the presence of sweat doesn't mean someone doesn't have heat stroke. And if someone has a high body temperature, heat exposure, and altered mental status, I'm going to start rapidly cooling them and treating heat stroke even if they're sweaty.
Thank you so much, Dr. Caleb. Yeah, this was a good test. I also was like thinking that, there's one way to assess sweat in heat stroke, and turns out there's not. So there's the importance of continuous research, investment in research and science. I'm going to stop that. Well, thank you again, everyone, for joining us. I think this question on heat stroke leads us well into the conversation we're about to have over the next 90 minutes, where because heat stroke and other heat-related illnesses are already becoming more common as the world gets warmer. Climate Central found that in the past 12 months across 2024, 4 billion people experienced at least 30 days of extreme heat, and that climate change doubled the number of extreme heat days that would be present without its effects. UNICEF itself, through its Children's Climate Risk Index, found that in 2021, approximately 820 million children under 18 years were exposed to heat waves. And in 2024, 1 in 5 children, or approximately 466 million, lived in areas that experience at least double the number of extremely hot days every year compared to just 6 decades ago. We're also seeing that this is leading to more droughts, wildfires, and disruptions in healthcare service delivery needed to address maternal, newborn, child, and adolescent health needs. So this really means that we need to figure out how the health sector becomes flexible and adapted to responding to these emerging needs quickly. So we're going to jump right into it. So to tell us how we can build heat resilient health systems, we have an introduction to the Beat the Heat framework from UNICEF by Abid Solomon, Senior Advisor of Environment at UNICEF. Abid Solomon is the Senior Advisor for UNICEF's Climate, Energy, Environment, and Disaster Risk Reduction Program Group, where he leads efforts to safeguard children's health and well-being from the impacts of climate change and environmental hazards. As the head of UNICEF's Healthy Environments for Healthy Children global program, he focuses on mitigating the harmful impacts of climate change and environmental degradation on children. He also provides strategic leadership for the Children's Environmental Health Collaborative and a partnership for a lead-free future, 2 multi-stakeholder initiatives that unite governments, civil society, and the private sector to create comprehensive solutions for protecting children's health from climate change and environmental hazards. Over to you, Abid.
Thank you, Swati, and thank you to all of the colleagues that have joined in to participate in this webinar. I was so enjoying the quiz. I thought we could just stick to that for the polls for this thing. It was so interactive. So I'll try to be brief. I have more slides than minutes, so I'll try to summarize it and essentially to say it is getting hotter. This slide actually shows that from the Lancet countdown back in 2022, that it is the number of person days that we're talking about in millions that we're experiencing is definitely increasing. And you have some stats, some that Swati already mentioned, some that I mentioned on the slide here, which will be available to everybody, but not to spend more time. And you'll see me flipping through slides really quickly because of that reason. But basically what we're talking about in Africa and Asia are the 2 highest regions where we are likely to experience, children are likely to experience more high temperatures, but also we can see very well in the Northern Hemisphere, in Europe and in the United States, also things are changing fairly quickly in terms of the number of person days that children experience and the kind of heat that children experience. Next slide, please. So one of the things that we focus on in UNICEF quite a bit is about the unique vulnerabilities of children. Why are children uniquely vulnerable? And of course, that doesn't mean they are the only vulnerable. They are outdoor workers that we know senior citizens are also affected. But there are certain things about children that are pretty universal, and this sort of illustrates what are the unique vulnerabilities in, and we break sort of childhood across the life course. So in pregnancy, so in utero, impacts of climate hazards, and also in infancy, in childhood, and in adolescence. We have a publication on this one, actually, the link to which that there is in on the slide here, which really deals with these unique vulnerabilities in a much more detailed way and applies it across climate and environmental hazards. So you'll see pollution as well. But speaking of extreme heat, and just to speak about infants, I mean, we know that infants have a much larger skin area compared to their body weight, a larger body surface area to their mass ratio. This means that they absorb more heat from the environment. And while, this larger air surface area can aid cooling, the effect of heat absorption is more pronounced, especially in intense heat. So you see more absorption that we have. They have underdeveloped sweat glands, so you don't see infants sweating as much as adults to cool down. And then the thermoregulatory system is still developing in infants. That puts them at unique risk. But then if you also think about behavioral challenges, infants are too young to figure out when to drink extra fluids to keep themselves cool. So there are these unique vulnerabilities we spend a lot of time thinking about in terms of how it plays out for children. So just to stress that as we think through this, because that sort of shapes the risk communication, how we think about it, how we talk about it is absolutely important, because it's not the same thing for everyone in the life stage. So let's go to the next slide, please. And we see a range of health impacts as a result. So there are some studies that point to a rise of 5% per 1 degree centigrade increase in temperature in terms of preterm births, and by 16% during heat waves. So you're likely to have more preterm babies, and that's how it actually plays out in terms of impacts. Sometimes you cannot even attribute it, but some of the studies are thankfully shedding some light on this. We also see that for stillbirths, and we also see the complications during pregnancy. So there are some strong data points to that. Next slide, please. But a range of health impacts as well. In terms of all complications in infants and young children. I'll not go through, of course, reading them out, but also in children and adolescents. So you think as children grow older, it's okay. And yes, it might be okay, but think about from a biological side, but then you have the impact in terms of learning that it's impacting because of extreme heat, and how it plays out in schools. And so that's really summarized in terms of what's all there in this particular guidance on protecting children from heat stress, the link to which that is there. It sort of provides that deep dive in terms of what the issues are, what the vulnerabilities are, what the health impacts are. But this is essentially how UNICEF thinks about protecting pregnant women, infants, and children from and other vulnerable populations from heat stress. And that is essentially about caregivers and frontline workers are able to beat the heat. And I'm going to talk a lot about that, because that's where the risk communication angle is, and that's the focus of this conversation. But we also focus, of course, on health facilities and their ability and their capacity to deal and address these issues, to manage and treat them, and to diagnose them effectively. And so for that, we talk about what needs to happen in terms of risk communication campaigns on Beat the Heat. So what is Beat the Heat? So Beat the Heat, BEAT, is actually an acronym. Be aware of heat stress and protect yourself. And this includes messages to protect yourself and your family and your community, as well as special measures for infants, pregnant women, and children. Easily identify the symptoms, some of the symptoms we just quizzed upon. And then what do you do about it? Act immediately to protect. And what are the first aid steps that we need to take, and then take to health facility? So let's go to the next slide. Just flipping through, what the be aware sort of. So this is all broken down into very specific behavioral things that we're looking for, actions we're looking for in terms of protection and promotion. And next slide, please. So this is about knowing generally, and then knowing how to protect community, and then what are the special measures for young children and pregnant women. So we'll not go through this in detail. And this sort of breaks down the guidance into sort of what the symptoms are for heat stress. And yes, the general symptoms we talk about, but what do you see in infants and children? What do you see in older children and adolescents? And what's specific to pregnant women? So the symptoms may be different, slightly different in terms of milder and more severe symptoms. So that's important for people to understand. But also the three-step process of reduced temperature. So what we need to do: cool and rush to a health facility. That's step 0 if it's too severe, and then reduce the temperature, rehydrate, and to remind how to protect yourself from heat stress. And of course, the last step is, which we don't want to happen in most cases, is to take to health facility, BEAT, and that completes it. And back to you, Swati, on this one. Thank you.
Thank you so much, Abith. It was a marathon to cover, I think, all the important information that is perfectly framing today's conversation. And I think, Abith, also for us to have a conversation internally about how do we reflect the new information we've learned about excessive sweating when it comes to heat stroke. So we're always learning, I think, from each other. So now what we're going to do is we're going to start this webinar by showcasing a government that is taking this issue very seriously. And so we're excited, and we were excited when a representative of the government of Belize was able to join us today, as Belize implemented its first comprehensive communication campaign just last year. So doing this presentation is Dr. Olusola Oladeji and Ms. Kathleen Azueta Cho, and they're here to share their case study on what lessons have been learned in Belize and from the experiences that they've had. Dr. Olusola Oladeji is a public health physician, holds a master's degree in public health and PhD in community health, and currently works as a health and nutrition specialist with UNICEF Belize. He has over 20 years of experience in health system strengthening, primary health care, including maternal, newborn, and child health, adolescent sexual health, reproductive health, mental health, HIV/AIDS, and public health and nutrition emergencies in development, humanitarian, and post-conflict contexts. He is also a fellow of Kofi Annan's Global Health Leadership Program. Mrs. Kathleen Azueta Cho is the technical advisor for the Health Education and Community Participation Bureau, the health promotion arm of the Ministry of Health and Wellness in Belize that is responsible for coordinating the health education and prevention programs. Ms. Kathleen holds a master's in public health with a specialization in epidemiology and biostatistics from the University of Melbourne, Australia, and a bachelor's degree in biology with a minor in psychology from St. Louis University. Mrs. Kathleen coordinates and monitors the programs and facilitates trainings in the area of nutrition, non-communicable diseases, environmental health, maternal and child health, both at the district and national level. Moreover, she supports the operation and oversight of the Community Health Worker Program and CD projects, including Love Your Heart and wellness initiatives such as Wellness Weeks in Belize. So over to you, Dr. Oladeji and Ms. Kathleen.
Good morning, colleagues. It's nice to be here to share our experience in Belize. The presentation, I'll be presenting my colleague, Ms. Kathleen from the Ministry of Health. We'll be looking at the introduction, the process for the adoption of BTE communication framework, community engagement approaches, and the installation of framework in the Ministry of Health and partnership. Next slide. We're going to show a video, one of the communication materials that we developed and currently being used in Belize. Can you play the video, please?
Slide's not appearing, Swati. Yeah. Sola, you're on mute.
Yeah, Belize has two seasons. Dry season, which runs from November to May, and wet season, which runs from June to October. During the dry season, the temperature is very hot, with very high humidity, and the temperature sometimes as high as 36 degrees centigrade. Recently, as a result of climate change, the country has experienced extensive heat and heat waves, which for extended period beyond the dry season into the wet season. There have been significant heat alerts declared by the meteorological services, particularly for the inland areas. There were reported cases of students collapsing from heat exhaustion in schools. The impact of intense heat in the country on the population was a concern to the government and partner, even though at that time there was no national policy and action on it. Next slide. When the BT communication framework was launched by UNICEF, UNICEF believes will engage the key line Ministry of Health, and Ministry of Social Development, Department of Environment. And following engagement with them, the framework was actually adopted as national campaign on heat stress in Belize. I will now hand over to my colleague for the Ministry of Health to show how the government has been using the framework in various instances. Over to you, Kathleen.
Yes, thank you. Now, for our risk communication campaign, it was very important to also include the community engagement strategies. So we explored the use of local champions, such as community health workers who are on the ground and many times the first point of contact. We also engage different influencers with TV appearances, local events such as health fairs and health forums, particularly wellness forums, which targeted different audiences. We also explored the school-based programs. Currently in Belize, we have the Healthy Habits, Healthy Schools, Healthy Belize initiative, which focuses on schools and proper nutrition, good nutrition. And lastly, we also explored more community-based settings, such as the use of mobile health clinics and other outpatient settings. Next slide. Now, the development and dissemination of communication materials, we looked at key messages using different communication channels. We use global videos, charts, and posters using the same messages, but also keeping in mind that we had to contextualize many of these messages. And because Belize is multicultural, we had to contextualize and translate many of our messages to Spanish, which is spoken in many of our migrant communities as well. So the videos and other key messages, such as reels, were posted on the UNICEF and the Ministry of Health and Wellness social media platforms. Next. But we also looked at other mediums of communication, given that we kept in mind that many of our public audiences also utilize other forms of receiving messages. So we looked at different audiences. Here we have our cane farmers who are also at-risk workers. We looked at other workplaces, which oftentimes involved at-risk workers who require water, who require shade and proper equipment, proper use of equipment. We also looked at food vendors, looking at food and the importance of avoiding food spoilage. And then we also looked at our general population, looking at ways that different persons could stay cool during very hot periods of the year. Next slide. Very importantly, the development of training materials also was an important area that we focused on. The Ministry of Health used posters, charts, and this was to provide training materials for teachers, and we partnered with the Ministry of Education, given that many times our students are experiencing symptoms of heat stress. So it was important that we also trained our teachers, trained our principals, and our parents as well. So the video that you saw earlier in the presentation was really focusing on schools. Also, we integrated the heat communication framework in our new revised national training manual for community health workers. They are a primary group that work in communities and oftentimes are the first point of contact in remote communities where maybe they don't have access to health facilities. So training these individuals was very important for meeting these target audiences. In addition, we also developed a document for health workers on climate and environmental hazards and pregnancy. Next slide. So most of the training, as I mentioned, focused on community health workers because they do come across pregnant women and young infants. Or pregnant women oftentimes visit mobile clinics, they visit the health facilities when they have to carry on their tests, to get their prenatals, to get different checkups. And so these individuals complemented the work of our rural health nurses who oftentimes render care to our pregnant women. Next slide. For us, it was very important keeping in mind that climate hazards like extreme heat could be associated to increased risk of complications during pregnancy. And this is why the CHWs were really the main targets for receiving the training on Beat the Heat. They're the first point of contact in communities that are oftentimes remote. Pregnant women and young infants are considered priority groups for these community health workers. And so the education sessions were done primarily during the mobile clinics when mothers visit the rural health nurses. And these sessions were also done at outpatient settings, such as what you're seeing here in the slide. And the messages focused on symptoms to look for, maternal responses, and what to do to prevent heat stress and dehydration in these groups. Next slide. So here you could see, again, the use of these community settings to provide and disseminate these key messages on Beat the Heat. Here we have a reunion mostly of pregnant women or women who bring their young infants, women who are breastfeeding. So we use this opportunity to bring information to these community settings. Next slide. Now, the awareness campaign also was used for important school campaigns, and this was during the Back to School Expo. We had a big health fair targeting students, teachers, health workers, and other community members, and it was a good opportunity to bring this framework to different audiences, particularly students. Next slide. Again, you could see this was done countrywide, so it was done in different districts, in different community settings. This was the use of health fairs to bring the information. And our community health workers or health promoters or educators are very creative. So they develop their own posters, they develop any material that can bring the attention to students, to different age groups, because kids have to be engaged. And so they had to develop games, they had to develop these campaign materials to bring the messages to these individuals. Next slide. Again, so you could see the creativity, the use of selfie frames to engage these younger groups. This was done at here at HQ. We engaged our staff as well to be part of this campaign because we are the Ministry of Health and Wellness. So we have to promote and be sort of the influencers for other audiences to, get on board with the campaign. These are some foamy boards that we we provide to our community health workers. They become creative, they develop these materials, and they take this wherever they go, and they can disseminate this information and educate. Next slide. So for schools, we also disseminated calendars for the year. This was part of the School Camp Back to School Expo. And the importance of drinking water was one of the key messages that was heavily publicized on different mediums. We also had different use of spaces. So here, even at the health facility, any space where people were accessing services, we utilize those as areas to promote these messages. Next slide. Now, the framework is being used to provide messages on our social media platforms, especially anytime that there's, heat alerts going out or being announced. You could see here our social media page, our Facebook page. The Ministry of Health is feeling concerned. We are experiencing very hot days. We utilize the framework as an important message to signal the importance of staying hydrated, of looking out for symptoms. If there's anyone who is feeling ill or sick during this time, they can contact their nearest health facilities. We encourage them to drink water and to stay hydrated. So the use of hashtags, very important to grab their attention, and these get many shares, likes, and we also look at the comments to see maybe what ways we could improve, or maybe what are some of the questions that the public might have. Next slide. Now, partnership was very instrumental. We partnered with the Miss Universe Belize franchise. Here we have our Miss Universe Belize, and she is a very important influencer. So her image was important in getting to other audiences, and she had a big reach, a huge base of followers, and her messages focused on health and wellness. So we pretty much piggybacked on her campaign of wellness and health to share our messages on Beat the Heat. She developed a video which was uploaded on her social media platforms, and we reached over 5,000 of her followers. So that was very good to pretty much capitalize on her influence to get the message out. The ministry also collaborated with Belize Red Cross Society to include the Beat the Heat communication framework in their first aid training package. They do a lot of trainings for the private and the public sector. So getting them on board as well, because they have their own audiences that they reach, was very important for us. Next slide.
Sorry, Ms. Kathleen, you have 30 seconds left.
Now, the U report was very instrumental as well for social messaging and data collection for young people that allowed them to speak on issues such as climate change. Next slide. Now, the first phase of this campaign focused on Beat the Heat, students, teachers, pregnant women, but it also helped the government to address other needs. And so this campaign was very important in seeing the needs of other target groups, such as at-risk workers who work outdoors during extreme heat. So there was training that focused on prevention, risk factors such as dehydration and heat stress, linked to non-traditional chronic kidney disease. So this is something that is currently ongoing, but thanks to the Beat the Heat campaign, we were able to see this and address this need. Next slide. So lessons learned, we were able to contextualize the tools and information from this framework to a much simple language and cultural appropriateness. We are now seeing that this is the status quo. Traditionally, the messages of staying hydrated, staying cool was prioritized during the dry period when, there was the Rutamaya challenge in March. Now this campaign has reinforced the importance of addressing climate change issues and bringing greater awareness on prevention messages. Schools have also adjusted their schedules during the warm, humid times of the years. Students are advised to drink more water, and some schools have gone the extra mile and made infrastructural changes to accommodate these students. And of course, the Healthy Habits, Healthy Schools initiative is currently ongoing. So we're using the Beat the Heat messages to complement the importance of good nutrition in schools. This campaign highlighted the importance of risk communication and community engagement principles as being fundamental in larger emergency response plans. And then the importance of community ownership. Our community health workers are now reaching out to schools, to cane fields, mobiles, once temperatures start rising. So this is now a routine practice for many of them. Thank you.
Thank you so much, Dr. Oladeji and Mrs. Kathleen. This was an incredibly comprehensive approach that the government of Belize has led on. And what I also appreciate is just how colorful it has been and so attractive. And I think that's an important part of risk communication as well, that it's very visual. And I think that's one of the lessons learned that you mentioned too. There are a couple of questions. I'm going to ask for very quick responses as we have limited time. But one question from Veronique Filippi on the call is, how is Beat the Heat acronym translated in other languages such as French? I'm curious, Miss Kathleen, what the translation was in Spanish, if you know that.
Yes, in Spanish, it was important for us to share the las síntomas or the signs of what to look out for, right? And we also stress the importance of what to do, las acciones, qué son las acciones que debe tomar la población, right? So I'm just giving some clips there as to keeping it short and in Spanish, and the use of images as well, because we realize that images go a long way. So using people from the community who look like them in these images was also important in that Spanish context.
Thanks, Ms. Kathleen. I think the question was asking also the acronym BEAT. Was there a translation for that in Spanish?
I don't have that on me, but again, we focused on the actions to look for more than the overall acronym, right?
That's fair. Thank you so much. I think you've also answered Asha Pun's question in part where about whether water bottles were provided for children to encourage them to drink water, or if schools had safe drinking water access. You had mentioned that schools adapted infrastructure. Would you have examples of what some of the schools did?
Yes, so through the collaboration with PAHO and other organizations who saw the need to jump on this campaign, there were water coolers provided as part of prizes for the schools who took on this initiative, and also the use of water fountains. I mean, that's a bit costly, but we did see a couple reaching out for donations and wider partnerships from the private sector to get these at the schools. And it became a common practice now for kids to take their water bottles. They decorated the messages there. And that's something now very common in ensuring that students get the right amount of water for the day.
Amazing. Thank you so much. Thank you again for this great presentation. I know there's one more question that we were unable to answer, but Ms. Kathleen or Dr. Oladeji, if you're able to answer it directly in the question and answer box, that would be great. In the meantime, I think we'll move on to the next presentation. So with this grounding, we'll now kind of cover the insights that we're gleaning from the latest research assessing the effectiveness of implemented risk communication messaging efforts, otherwise, known as implementation research. And so kicking us off is Dr. Caleb Dresser, who is an assistant professor of emergency medicine at Harvard Medical School and an assistant professor in environmental health at the Harvard T-Chan School of Public Health. He also serves as an assistant director of the Physician Fellowship in Climate and Human Health, leads work on healthcare solutions at the Harvard Chan Center for Climate Health and the Global Environment, or Harvard Sea Change. And he is also on the Faculty of Emergency Medicine at Beth Israel Deaconess Medical Center in New York. a major teaching hospital of Harvard Medical School. So over to you, Dr. Dresser.
Thank you so much, and thank you to everyone who's taking time out of their day to talk about heat and what we can do for our patients and the populations we serve. I'm going to be fairly brief and essentially showcase some resources and share the approach we've taken to understanding how these are used in practice and where we want to go with this. I do have a couple of disclosures. The main one relevant to this is that the toolkit we're talking about was funded through a gift from Biogen, which is a private corporation. I'm not talking about any drugs or devices that company produces in this talk. Next slide. So we're going to be talking about the Climate Resilience for Frontline Clinics Toolkit. This is a resource that is freely available. The QR code on the slide will take you there, and we can drop the link in the chat as well. And this includes resources in English and Spanish for patients and providers and administrators on a range of climate-related hazards, including heat, which is what we're going to focus on today. Next slide. So as a little bit of background, I think it's worth pointing out that this resource is really aimed at healthcare and the interactions between healthcare professionals and their patients. This fits into a larger whole of society response that we need to the threat of heat, right? If you're thinking about young children, pregnant women dealing with heat, part of this is about interactions with nurses and doctors and counseling we can provide, and that's what the toolkit is focused on. But I think it's important to contextualize that and point out we also need excellent public health programs, as we just heard about. We need effective early warning systems for heat. We need investments in critical infrastructure, whether that's clean water to drink or power to run air conditioning units if that's available to the population. And in addition to that, clinical resources like we're talking about today. So this is, I think, one piece of a larger puzzle. This is a resource that is really focused on the unique relationship that doctors and nurses and other health professionals have with their patients. These are trusted individuals. They're in a unique position to provide advice and counseling. And this advice and counseling can be tailored to the specific needs of individuals. So this is a particularly interesting way to get information into the hands of people who are at highest risk. Next slide. For a little bit of how we got to where we are today, this project was initially led by Dr. Ari Bernstein, and under his leadership in 2021, a needs assessment was conducted by AmeriCares and Harvard Sea Change, reaching about 430 people who work in free and charitable clinics and qualified health centers in the United States to understand how were climate-related hazards, including heat, affecting their patients and their practice, and to ask, what do you need? And one of the big things that came out of that was that a lot of people are seeing impacts and that they wanted informational resources that could support engagement and counseling with patients. There's a couple of publications listed here that you can read if you want details on that research. Next slide. So the result from that was approximately year-and-a-half development process that included both extensive literature review, expert engagement, and also co-development, focus groups, interviews with potential end users of these products, and then small-scale piloting to understand whether this actually made sense as a clinically useful resource in those settings. That ultimately led to the creation of a first version of this toolkit, which was released in late 2022 and then was piloted in 2023. And you can see on the right what some of these resources look like. This is for pregnancy and heat on the right. And this was information that a nurse practitioner might be able to access to get a quick 2-page summary of what does heat mean for a pregnant patient under my care. Next slide. So in 2023, I took over the project and we ran a clinical implementation with 19 clinics in collaboration with AmeriCares, which is a large humanitarian nonprofit. And this is a map of where the pilot sites were for this project. These were free and charitable clinics, mobile health clinics, federally qualified health centers, typically serving high-risk patients, people who might have financial limitations, mobility limitations, and often were living with some combination of chronic disease or financial challenges that affect their exposure to things like heat and flooding and other climate risks. This included a number of focus groups with participants in this pilot at the clinics to provide ongoing feedback and also share how they were using these materials in real time. Next slide. We then did both surveys and semi-structured interviews with the staff at clinics that had implemented these resources. The graph on the top right is a little hard to see, but the takeaway here is that it's a small sample size survey, but there was a pretty dramatic increase in level of confidence about knowledge on preparedness for things like heat. And in our semi-structured interviews, which you can read about in more detail in our publication in the Journal of Climate Change and Health at the bottom right, we heard a lot from people who used these resources about what was working, what wasn't working, what some of the implementation challenges were in their clinics, and what they thought we could do to make this better. You can read a lot about what that looks like in our publication, which I can drop a link to in a few minutes. And then we also updated the toolkit based on this feedback. Next slide. So we convened about a little over a year and a half ago, we convened a series of expert working groups and continued to work with the clinic users of these materials to release a updated version of the toolkit that was intended to cut down on text, reduce repetitive text, increase the number of pictures, and provide information in a way that was more aligned with how people were actually using this in practice. So on the left, for example, you can see a handout intended for pregnant women. On the right, you can see the very condensed text in a tips for people with specific health conditions or risk factors sheet that's designed to be a single thing that can be printed out in a general family practice clinic. And then if you're treating a patient who has a small child, you circle that part of the sheet. If your patient is pregnant, you circle that part of the sheet. And so it's easy to logistically in a clinic provide the right counseling with one single printout. You don't have to keep track of a lot of different sheets. Next slide. We also increased the amount of visually representative stuff. And having just watched the last presentation about work in Belize, I really love the visual aspect of this, right? This is how people engage. This is how people get excited. And this really helps people connect the dots, particularly if you're working with low literacy populations. And so we dramatically increased the amount of visual aids scattered throughout the toolkit. Next slide. So at this point, we have a lot of ongoing work. There is currently a freely available toolkit for the United States available online, available in English and Spanish. We've also had the privilege of collaborating with AmeriCares and the Philippines Department of Health to develop resources for the Philippines. Those will be publicly released later this summer. And this is a quick screenshot of one of those materials, in this case translated into Cebuano, which is a local language in the Philippines. With the idea, again, of trying to make visually accessible, interesting materials that can reach people who are at highest risk. We also have work going on in collaboration with folks in Australia and in the Mediterranean region, and I think there's a lot of opportunity for building out resources like this in other regions as well. Next slide. So just to give you a sense of how much these resources are being used, we've had tens of thousands of downloads and page views, and these continue to tick up over time. So I think these are getting used at scale. Next slide. And as we look ahead, I think it's really important to develop resources that are tailored to the language and hazard profile and resource contexts in which they're going to be used. Heat counseling in a high-income setting in the United States may be very different from heat counseling in settings where resource limitations or power grid stability are more problematic. And we also need to put some real time into validating that these things work, right? The implementation research, the outcomes research needs to happen in a rigorous manner. So happy to chat more if people have questions about that. And thank you so much for listening.
Thank you so much, Dr. Dresser, for the quick but very insightful presentation, and love the reinforcement of the idea that we need more visuals in our communication to help the material feel more accessible for multiple populations. So now next up are Dr. Chuanxi Gao and Dr. Isabel Launch, who will be covering another ongoing implementation research project that's looking at messaging on pregnant women and extreme heat reaching users of early warning alert systems. So over to you both.
Thank you. So we are going to present an ongoing work developing an early warning system that is Mother Heat Alert. Is a mobile phone app with integrated heat health messages. And so I will be presenting the first part, and Isabel will continue. So there are 4 elements for people-centered early warning system, and that is risk knowledge. So which type of hazards? Of course, today we are focused on heat and vulnerability, as we have heard, pregnant women and children, infants, so they belong to vulnerable groups. And we need to monitor and provide warning service. And we need to monitor the right parameters. For example, the heat actually is not only the temperature, as we heard. For example, sunshine, humidity, and other factors will also affect the heat level. And the third one is dissemination and communication. So this is the focus of this webinar. And Isabel will talk more about this. And then the fourth one is the response capacity. So we need to build up national and community response capacities. If there is a risk, how should we act? How should we do? Next, please. And the first one, I explained it more, the risk knowledge. So obviously the hazard is the heat. So we know we have more intense and frequent heat, which will cause more mortality, and not only mortality, but also morbidity and different types of heat-related illnesses. And heat has a great impact on vulnerable groups, as we have heard. So it's not the same impact on everyone, but for healthy and fit people, the impact is smaller. But we need to focus more on vulnerable groups such as pregnant women and children and infants. Next one, please. And in our previous EU project, it's called CliMap. So we use the concept to develop personalized heat health early warning system, which is a mobile phone app. So we extract the local weather forecast, that is the thermal condition, the weather condition, and then integrate with other factors that can affect our body heat balance and heat exchange, then combine them together, then do a risk assessment according to the threshold, and then provide health risk warning. And based on the warning and the risk level, then we provide different messages for the users to take actions. So these are all combined in a mobile phone app. Next one, please. Yes, in this ongoing project, this is called High Horizons, and this is funded by European Union and the UK Innovation Foundation. So the early warning system is called Mother Heat Alert. This is another mobile phone app. In the middle, we can see the profile. So if we are going to use the app, so we need to import our profile. That means some of the vulnerabilities are also integrated here. Once we have import our some of the information, for example, from which country and what is the age and what is the gestation age. So it's a 3 months pregnancy or 6 months or 9 months. And this will be integrated, and then based on the vulnerability and the heat level and the risk assessment, then we provide early warning alert, and then further provide a message. Next one, please. And this warning and recommendations for actions are based on the heat risk threshold. These are integrated into the early warning system, and the personal profile, as I mentioned, which integrated vulnerabilities. And it provides today's risk and the next few days, like 2 to 7 days. And the Mother Heat Alert is now being implemented and tested in 3 countries, in South Africa, Sweden, and Zimbabwe. And based on the test, we're going to evaluate the effectiveness and the usability of the early warning system. So this is ongoing. The data are being collected through the app and through another platform is called RedCap. And there are several questionnaires and through face-to-face interviews. And now this is done internally within the project. So we're going to involve 600 pregnant and postpartum women. And after the project, we plan to make the app publicly available and operational. But there are also some challenges since this is a research project. The time period is limited. Is a 4 years project period. After the project period, usually the funding is ended. So we are also looking for opportunities to make it operational. And that means we need some update from time to time and to maintain the operation. We need some smaller funding for long-term operation. Maybe UNICEF is able to do this. I'm not sure. And regarding the message, on the right-hand side, we can see the message provided in the app. And then the question is, how were those messages generated? So Isabel is going to present more about this. Thank you.
Thank you. Thanks everyone for having me. So after Shwanzi has set up the context for this app and the messages, I'll share some of our insights from our work co-developing these heat health messages for the app with pregnant and postpartum women in South Africa and Zimbabwe. So we've already heard today how pregnancy increases vulnerability to heat stress, but what's often overlooked is that the way women can or cannot respond to heat events depends deeply on context. Cultural norms, living conditions, access to resources such as water and shelter, decision-making power within communities and households. And so tailored context-specific messaging would be essential for any such app. In order to do this, we wanted to understand how the messages would work. Sorry, I realized we don't have much time left, so now I'm flying. Here's the slide. We developed a theory of change to understand. We can't spend time on it, but you see the early warning system on the left, and on the right are the actions. And we wanted to understand how the app and the messages would travel through a community and how a woman would use them in order to actually change knowledge and behavior and then change her actions. And that's everything from the availability of mobile networks to the timing of messages, engagement of family. Next slide, please. So how did we co-create these messages? Social science teams in each country applied a participatory research approach using photo voice, qualitative transect walks, and focus group discussions. And with photo voice, we asked women to take pictures that represented their relationships to heat and how heat affected their pregnancies and postpartum lives and caregiving. And this also included discussion workshops with body mapping, focus group discussions. We also spoke to community health workers because they, as we've heard already too, that they're quite involved in pregnant women and postpartum women's lives. And in Zimbabwe, there was a public event, part of the Photo Voice, that included community members to discuss the dynamics of heat and pregnancy, which also informed message development. Next slide, please. So here is just some of the pictures that women took. You can see some images from South Africa, such as cooling swollen feet in water and the distances walked in the heat without shade that are then described in these narratives by women. And in the next slide, you can see 3 women in Zimbabwe presenting their photographs to the community where they were able to engage and raise awareness of the links between heat and maternal health. And the next slide, please. Ultimately, what did the messages look like? They were meant to be practical and had realistic guidance, had simple behavioral tips, about resting, clothing, hydration, including guidance on how much to drink and being specific where possible. They were supposed to be feasible and appropriate and have the right language. We also had icons that organized these messages into categories. And then the next slide, just some quick key learnings, is that the social life of these messages matters. For example, in Zimbabwe, we realized that messages had to involve household and community, not just the women. Proposed changes in behavior, like resting more or delegating work, had to be explained to husbands and families. They also had to be a part of the intervention. And then structural constraints also played a huge role. We couldn't suggest behavior change in the messages that wouldn't be appropriate for urban settings, for example. We also got the sense that trust and cultural fit of the delivery channel matter as much as the content. And so this is what we're going to learn more about now in the evaluation. Was this the right channel to distribute messages? And is this a good way of getting them across? So the next slide, please, is just some takeaway here on it's important to remember that effective heat health communication for women is not just about what's said and messaged, but how it's developed, negotiated, and applied within relationships, roles, and realities. And the next slide, just to thank you.
Thank you so much, Dr. Lange and Dr. Agao. I know that was quite a short time to share so much important information and research that's coming out of your project, and we look forward to also giving you a platform to present the phase 2 results as well. With that, what we're going to do is we're going to take a quick break and do a little bit of a poll. Because we have so many presentations, we want to make sure that you have a time to actually reflect on what this information looks like in your own life. So we just have 2 questions for all our participants who are still with us. We still have another half hour, so giving you a little break to think about your experience. So we just have 2 questions here for you. One is, have any of your medical providers talked to you about how climate change is affecting your health? So in any of the appointments that you've had, have you heard your providers talk about this? And then 2, where do you go to get trusted information on how to protect yourself during heat waves? So what are the different channels? If you can think about all the different places where this information is, what's your reflex when you think, oh, what temperature is bad again? Where do you go to figure that out? All right, great. We have about 20% of the audience answering. Lynn, I might ask you to come in again because I don't think I can see the answers on my side.
Sure, no problem. We have about 40% of the people responded. Let's give it another second, see if a few more will come in.
Yeah, let's get about 50%. So if you haven't responded yet, please take the chance to respond, and then we can talk about what everyone said. Okay, great. So I'm going to end the poll now and share results. Lynn, are you able to see it? Yeah.
Yes, and colleagues should be able to see it as well. I've just hit shared. So for the first question, have any of your medical providers talked to you about how climate change is affecting your health? The majority, actually 90%, said no, not yet. Next is at 6% yes, but just once or a couple times, and 3% yes regularly. So that's surprisingly small. And then where do you get trusted information on how to protect yourself during heat waves? Some really interesting responses here. The biggest one is Google. So I think that's no surprise. Searching. We've also got government websites, state and local websites, media, medical professionals. We have CDC, we have NOAA, we have NHS, government sources, and Weather Channel.
Great, thank you so much. Well, it's good to know that I think we see that there's some sort of agreement on where the trusted voices are. And so I think that's part of risk communication, right? Making sure that the right person is telling you this information as well, someone that you respect and someone who has the right knowledge about extreme heat and what it does to the body. The one person I think who said, yes, my provider regularly talks about climate change with me. If you want to put in the Q&A box what type of provider this is or where you're joining from, it'd be great to kind of know, this unicorn experience. You know, as we have more and more doctors, I think becoming advocates, climate advocates as well, hopefully the ratios of yes to no will change over the next few years. Perfect. And so now what we're going to do is go into our next two quick presentations. And so we'll now dig deeper into the messages themselves and what the research is showing in regards to what information is resonating with pregnant women and caregivers. So kind of complementary to the work that was being done by our previous presenters. I don't have enough time to go into speaker bios, but I will definitely be sharing them in the email that I send afterwards as well. So over to you, Dr. Kadio, who is a researcher from Burkina Faso, to share about her project.
Can I share, please, my slide by myself?
Yes, definitely.
Mm-hmm.
Over to you.
Okay. Can you see my slide?
Yes, yes, we can.
Okay, thank you. So today I will talk about our Shamna project that we developed in Burkina Faso to try to understand how to reduce the impact of exposure to heat on pregnant woman, mother, and newborn baby. But today I will focus on the communication tool development process. Before I will talk about Burkina Faso, it is a Sahelian country and Francophone country in West Africa. It in very, very hot country, and sometimes the average annual temperature can vary between 25 degrees Celsius and 32. And the height temperature can attain 42 degrees Celsius in specifically March and April month. And in this context, sometimes heat is very considered that a normal, and the exposure to extreme heat may be not recognized that a heat health problem by the woman. To address this problem, we implement a research on heat and maternal health in Burkina, and we try to understand how exposure to extreme heat during pregnancy and postpartum period was perceived by women and health professionals. And then we could develop and implement a climate change adaptation intervention. To address this objective, we developed a series of, we try to answer a series of research questions. And yeah, we use three approach methodology: quantitative research to address how extreme heat affect breastfeeding practice, and qualitative approach to answer how women and stakeholder experiences and perceive heat affect during pregnancy, childbirth, and postnatally. And after we could design and implemented intervention. In this slide, I put the links of the different papers that we publish after this research. And this slide, you can see the paper, and you can check when we will receive the slides. And my today presentation, it is focused on message development to improve women knowledge of the negative effect on extreme heat and on adaptation strategy. How we develop the message, we use 2 steps to do that. The first step, it is identification of behavior. And the second step, we formulate the message. To identify the behavior, we use the qualitative research result, the co-design workshop result, and a review of scientific literature in Burkina Faso. And we use this information to identify woman beliefs, attitude, and practice that could be targeted in behavior change intervention. And the qualitative research shows some woman belief, attitude, and practice. For example, some potential harmful behavior were reported that a coping strategy to deal with it. For example, supplementing breast milk with herbal tea. And so the influence of certain local belief and practice relate to heat exposure. I will talk for that later. And Shamna team focused on this result and decide to address breastfeeding and hydration in preyoung and postpartum women and discomfort. And concerning the harmful behavior regarding breastfeeding, qualitative research highlight that a woman and community member believe that in very hot weather, giving only breast milk cannot quench the baby's thirst. For that, they give water and do not practice exclusive breastfeeding. And second time, concern mother hydration, the qualitative research and show that women believe that drinking fresh water is better, but there are some local belief that drinking fresh water during pregnancy is risk, and this may result in increased fetal growth, leading to a difficulty deliver. And additional, there are belief that drinking cold water during the postpartum period may delay woman recovery. This is a local belief about heat and mother hydration. For discomfort, we noticed that they had high ambient heat makes breastfeeding uncomfortable. For example, women sweat a lot of, and baby cry, a baby cannot, baby refuse to breastfeeding in cry, and this moment is not comfortable for a woman. And after to identify this harmful behavior, we try to formulate a message to address this. And we organize a series of 4 discussion group, a workshop between Shamna team and clinician for Burkina Faso. And we use information about harmful behavior highlighted by qualitative study and the evidence from scientific literature, for example, how to quit hydrate. And we discussed on the co-design workshop and had highlight the need of the chat message to part of behavior intervention. And this is, in this slide, I share some example of content of message. For example, for breastfeeding, one message support that breast milk contain enough water for a child need, even when the ambient temperature is high, and to provide advice on the frequency breastfeeding in hot weather. And for the discomfort, we give example to how to reduce discomfort. For example, short shower can help mom to feel better. Yeah.
Sorry, Dr. Kadi, we only have 1 more minute, so if you would like to
Yeah,
go to
this
keep it
is
going.
my last slide. And we develop and tool with this message, and health provider use this tool to integrate heat and hydration message in their routine work in preyoung and postpartum women. I will just quickly share the tool. Did you see my slide, please?
No, sorry, it has to switch. I think you have to unshare and reshare.
Okay, sorry.
Oh, sorry, I'm seeing a slide. Are you sharing something else?
You see the picture?
On the right, but not just a picture. We see the
Okay.
slide, yeah.
Okay. One moment.
Yeah.
Yeah, this is the tool that we developed, and I just show you quickly. Yeah, this is about heat and exclusive breastfeeding, and we put a message for that health provider and community health provider can use to share information for mom during the activity routine in health facility. Yeah, this is I put the link in presentation, and you can check. Yeah.
Thank you so much, Dr. Kadi.
Yeah.
I think there's also a lot more information in Dr. Kadi's presentation, which you will receive. You will receive a copy of the presentation, so you can actually go through all the other work that her team has done that she hasn't been able to present today. But this has been really great to learn about, I think, daily behaviors like breastfeeding and how that needs to be part of the messaging that goes forward as well. So thank you so much, Dr. Kadi. And now we're going to go on to our last presenter, Hamid Kashan from UNICEF. Just want to say, isn't it typical for any webinar, no matter how long we make it, we'll always run out of a Q&A period. But that is okay, because I know some of our panelists have been answering your questions in the Q&A chat itself. And then if there's any other questions that are remaining unanswered, we will try to put it in an email to you guys. But now I'm going to hand it over to Hamid to take us through social listening and what social listening is saying about extreme heat. Over to you.
Great. Thank you very much, Swati. Team, I'm going to go a little bit faster in the interest of time, so apologies in advance. Can we go back to the previous slide, please? So I wanted to start with saying that I think everyone on this call would agree that before we start communicating with anyone or start designing any intervention, the first step is for us to start listening to communities. And in this presentation, I'm going to talk about how active listening to communities can be a powerful impetus for field level action, specifically on extreme heat. My name is Hamid, and I work with the UNICEF SPC team on social and community listening and digital engagement. Next slide, please. Today, I'm going to share with you how we listened to the communities about extreme heat, what we heard, and how we are planning to act on this and what you can do about it as well. Next slide, please. Let's start with why listen. At UNICEF, we believe that what people say to each other is a strong predictor of their behavioral indicators. We believe that what people say to each other when unobserved affects how they perceive reality, and it shapes their actions. This is why we've designed an entire stream of activities called social and community listening, SCL for short. Social and community listening is a systematic process of tracking what people say publicly, whether they're expressing themselves on social media, to their journalists, engaging with our frontline workers, or participating in our research activities. No matter what people say, where people say it, if it's public information, we can tap into it, listen to it, triangulate insights based on that, and connect it to programmatic action. So to that end, we partnered with Abit and the team here to listen to communities in 5 countries. These 5 countries were Bangladesh, Brazil, India, Indonesia, and Senegal. And we collected data from 1st May 2024 all the way to 31st May 2025. And the goal was to identify what communities are saying about extreme heat, where the gaps are, and what programmatic teams can do about it before the next heat wave strikes. Next slide, please. So how did we listen to communities? We started by connecting with our field teams. We started working with them to co-develop local language Boolean queries. These queries are critical because once we know the terms and the terminology that people use to talk about extreme heat, we can create data collection mechanisms and filter out irrelevant data. We also use the same queries to exclude non-public data sources. This engagement with our team members in the field was essential because without them, we wouldn't know which channels we need to listen to. In this particular research, we had majority of our data coming from X, Facebook, Instagram, TikTok, but we also had data coming in from online news, broadcast transcripts, community feedback channels, and also our own programmatic data, including UN data hubs. We then collected and anonymized all of this data to put it through our database. And that database was then tagged through AI-based custom trained models. We used natural language processing to cluster information, to identify sentiments and entities. And then we did a manual coding for behavioral signals and misinformation narratives. At the end, we had a normalization exercise where we used an indicator that we created called mentions per million internet users, so we could look at all the narratives that we're collecting across all these 5 countries and compare country A to country B. Next slide, please. So what did we hear? Out of the 244,000 results that we analyzed, only 8% mentioned children. And even when they were not mentioning children, majority of the conversation was focused on the outputs of extreme heat, such as the temperature itself or power outages in majority of these countries and the heat effects itself. What we did not see were a couple of narrative gaps that I'll highlight. We also noticed that the way people talk about heat differs from country to country. For example, in Bangladesh and India, heat is often looked at as an annual occurrence. It's just part of the seasonal cycle. In Bangladesh, though, there was some expression of caregiver anxiety. But in both India and Bangladesh, we saw a lot of humor and a lot of memes around heat. We see that happen when communities feel that they don't have the right tools or information, or they don't feel empowered to tackle a challenge. They use humor to deal with such situations. In Senegal, we saw that even though there was very limited data and very low information talking about extreme heat, it is an increasing trend. There were increasing signs of awareness and calls for better urban planning and solutions. When you contrast it with Brazil, we saw huge engagement. The media is highly involved. Young people are very actively calling for urgent action, and we saw numerous occasions where people are sharing tips with each other and solidarity messages around heat waves. In Indonesia, this was unique because that was one of the few places where we saw that people actively connected heat with health. That was not the case everywhere else. We also saw caregivers, without prompting, sharing with each other tips on how to deal with heat. The narrative gaps that we mentioned earlier included infrequent or almost no mentions of child health hazards and child rights framing of heat. We also saw no mentions of long-term development hazards to children or risks to their learnings and people's livelihood. Urban planning also was largely missing, and we need to make that a part of the discourse. Next slide, please. So based on what we heard, what can we do about it? What can you do about it? The first recommendation is that we need to take holistic action. This holistic action needs to integrate strong behavior change component in every program response and reframe heat risk as a child health hazard, not just weather. We need to listen to and promote local hazards and local solutions. By doing that, we make our interventions far more powerful than what any of us can do by ourselves. And lastly, we need to mobilize trusted messengers. The trust that they already hold will increase the effectiveness of our messages that much more. And lastly, we must blend digital action with community level interventions. One or the other is not going to be enough for sustained behavior change. Last slide, please. The full report is going to be released in the next few weeks and includes other hazards as well. I'm going to thank you and encourage you to keep listening.
Thank you so much, Hamid. What a perfect way to end this webinar, emphasizing the importance of local perspective and locally led solutions. We're realizing more and more these days that one size does not fit all, and it's great to see the evidence behind that anecdote. With that, we only have a minute left. Oh my gosh, how fast this webinar has gone by. I want to thank all of our presenters for joining, also the Children's Environmental Health Collaborative and the Global Heat Health Information Network for co-hosting this webinar. I just want to say that we have 2 more webinars that will be coming up. The next one will be talking about efficient management of heat-related illnesses in patients, particularly women and children. And then also the last webinar will be talking about government protocols and which governments have a ready-to-go preparedness and action plan in place. I see there's a hand raised. I've taken note of all the questions. I do want to give this last minute to maybe Mrs. Kathleen, if she's still here. If you'd like to share a quick reflection on everything that you've heard so far. And if you think it's something that the government of Belize would be interested in acting on.
No, I just want to say thanks to all the presenters. I really enjoy all the presentations, and I could see the use of these technical experiences, especially those done, at the development of the messages and the community engagement, and having that component be very integral in messaging. So I really enjoyed those presentations. Yes, we would. I wanted to share too that I think these are very important mediums that we could get best experiences from various countries and see how we could adapt and learn from these experiences in our own communication plans. So yeah, that's what I have for now. I know we're pressed with time, but I look forward to supporting and engaging in similar sessions like these. Thank you.
Thank you so much, Ms. Kathleen. We're very excited to continue our work with you as well. And for everyone who's joined, we do have a quick feedback form on how we can make our future webinars more engaging, interactive, and useful. Please just click a lot of boxes for us, and we'll make sure that that feedback is integrated. Thank you all for joining us today. Please stay cool, please drink water, and take care of yourselves, and we'll see you again soon. Bye.